morning, everyone. I think we're ready to start. So I am going to welcome everyone. I am the editor of a media startup in South Africa, the Bekisisa Center for Health Journalism, and I'll be co-moderating this webinar with Dr. Sina Parastaran. On the webinar program that's been sent out, you will see that Sina and I will make turns to moderate sessions. I'll be doing this first bit, and Sina will then do the first best practice session and also the concluding session of this webinar. Now, as you may know, this meeting is hosted by the South African Young Academy of Science in partnership with the National Young Academies of Science in the Democratic Republic of the Congo, Mauritius, and Zimbabwe. And our discussion today is part of a SADC-wide project that stems from a collaboration between the Academy of Science in South Africa and the United States National Academy of Sciences. And the purpose of this collaboration is to implement a project to disseminate policy briefs on non-pharmaceutical interventions for COVID-19. So during this webinar, we'd like to do a few things. The first is to discuss the successes and challenges of the implementation of public health and social measures by governments in the SADC region during the COVID-19 pandemic. And we'd also like to highlight best practices across SADC regions and countries. And you'll notice from the program that there are quite a few Q&A sessions that has been scheduled, and we'd love to get your input so that it can be incorporated in the policy briefs that this project will produce and distribute among policymakers. We'll now move on to the welcoming session, which will be presented Professor Rula Inglesi-Lotz. She is an associate professor in the Department of Economics at the University of Pretoria, and she's also the co-chair of the South African Young Academy for Science and a member of the Global Young Academy. Rula, over to you.
Thank you very much. Good morning to all. On behalf of the Executive Committee of ZIMYAS, I would like to welcome you all also to today's webinar. As mentioned before, organized in partnership with the National Young Academies of Science in the Democratic Republic of Congo, in Mauritius and Zimbabwe. I sincerely want to commend the organizing team of this webinar, as cooperation and collaboration at regional and international level has proven essential in the current challenging circumstances we all experience. The public health sector's strengths and weaknesses became even more apparent during the COVID pandemic. I am hopeful that today's discussions will draw on lessons learned from various countries and best practices, specifically in the SADC region. And all of this should be under the lens, of course, or prism of promotion of evidence-based knowledge and promotion of scientific rigor that is so needed in our days, that are both in the heart of ZIMYAS and other Young Academies mandates. I wish you all a fruitful and interesting morning, and I would like to express special gratitude to moderators, panel discussants, and presenters for their time and effort. We know that time these days is a precious commodity, so we thank you all for your time this morning. I wish you all a very good morning.
Thank you very much for that, Rula. This was a great welcome note and has set the scene for the rest of the webinar. And for a little bit more background, we're now going to hear from Professor Puleng Sekgalo, after which there will be an opportunity for questions from all of you. If you have a question after Puleng has spoken, please raise your hand, but also enter it in the Q&A box so that I can see it and know what your question is. The reason for this is that if your connectivity is good, I'll get you to ask your question on video or audio, but we know that internet connections sometimes fail us. So please do enter your question in the Q&A box so that if your internet connection isn't good, I know the question that you wanted to ask and I can pose it to Puleng. Let me introduce Puleng first. She's a Fulbright scholar and an associate professor of psychology in the College of Human Sciences at the University of South Africa. She's also a member of the South African Young Academy of Science and belongs to the working group on policy influence. Puleng, over to you.
Thank you very much, Mia. Good morning, everyone. I'm going to try and share my screen with you because I have a PowerPoint presentation. Okay, Mia, can you just confirm that you can see the PowerPoint?
Sorry, I can't see it. I don't think the others can see it either. I think there's a green share screen button at the bottom.
Oh, okay, it has been disabled. So, Kolani, I need assistance. Kolani, if you could please assist me. It says the host has disabled my screen sharing, so I cannot share my screen and I need to show the PowerPoint.
Okay, watch this thing now.
We're just waiting for Puleng to get assistance so that her share screen button can be turned on, and then we'll move forward with the program. Kholani is just talking to the technical person.
Okay, excellent. You should be able to see it now. Okay, once again, good morning, everyone. As has been indicated, what I'm going to provide is the background and just a broad overview of the project that we're busy with. But before I can get to that, I just wanted to give an idea to maybe the colleagues who are in attendance who might not have information on Young Academy of Science. So the aim of Young Academies of Science around the world is to have a group of young scientists in different regions in the world to represent young science leaders in the different regions that they exist with. And the idea is to make sure that we have a unified voice of young scientists who contribute towards evidence-based information, but also towards policy making and making sure that we facilitate science engagement, public science, and make sure that there is dissemination in terms of the work that is being done by scientists in the various sectors that they occupy. So that is what Young Academies of Science are about. And now in relation to this particular project, it's still part of the broader mandate of what we do as young scientists. Again, is representing young science leaders and utilizing evidence-based approaches to make sure that innovative work is given attention and is given a platform, and to ensure that we use science to address developmental challenges. So even in this moment of COVID-19, the idea is that we need to look at the ways in which science can assist us to find possible solutions to ensure that we respond to the challenge of COVID-19 so that it can be defeated. And now I'm just going to be sweeping through this. We just wanted to give you an idea of some of the work that the young scientists have been doing since the lockdown, in particular in South Africa. So SADC in South Africa, many of the young scientists responded to the challenge of COVID-19 in many different ways. So what you have here is a number of young scientists who have participated in varying ways. So you'll see Professor Alex Broadbent, Professor Willie Chinyamurindi, and all the other colleagues who have participated in responding to COVID-19. as part of the work that SADC do to make sure that we respond to issues around challenges within the spaces that we occupy. And again here, this is just a snapshot again of some of the Young Academies of Science initiatives that we're doing, both in South Africa, but in other regions with other colleagues that we work with as well. Again, another snapshot of the initiatives that we do as Young Academies of Science. And this one in particular was also something that was very important, because we know when it comes to dissemination of information, sometimes people get excluded because of how the messages are relayed, but also because of language, so the challenges of translation. So there might be information that might be useful for people, but people will end up not benefiting from that information because they cannot understand. So some of our colleagues, the young scientists, took it upon themselves to make sure that they work on a project of ensuring that some of the brochures, the messages that are being sent out to the communities are also translated in the various indigenous languages as well. So here we see an example of such information being translated in Lingala. So the overall objectives of this particular project that Mia introduced in her welcoming is that we are looking at the dissemination of policy briefs on COVID-19, but in particular non-pharmaceutical interventions in the SADC region. So that we know there's been a lot of information that has been disseminated. There's been a lot of research that has been conducted all around the globe. And the idea is to look at all this information and look at the policies that have been put forward, the briefs that have been put forward, and be in conversation with those and look at how they resonate with the grassroots level, but also resonate with the experiences of the frontline workers and people doing the work on COVID-19. So this was or is a collaboration between ASAF and USNAS, National Academy of Science, that they implemented this project to disseminate policy briefs that have been produced and prepared by their partner organization called Resolve to Save Lives. And this, as I said, was particularly to focus on non-pharmaceutical interventions that have been put in place in the various regions in the world. And so for our part, we are focusing on the SADC region. So the idea is to engage experts, is to engage you as participants today to be in conversation in these regions on key messages and recommendations on these policy briefs. So as part of the invite, we also shared some of the documents that have been produced as part of these policy briefs. And the idea is to look at what messages are being put across and what recommendations are put in place. And are those resonating with the kind of work and the experiences that we are having in the different regions that we are in. So, and looking at how the experiences of COVID-19 are being responded to from the different regions that we're finding ourselves. So with this, our outcomes, our hope is that we especially today, is that we can have a conversation, we can have a discussion where we look at the successes and challenges. So over and above these recommendations that we have, the policy briefs, we need to look at them in relation to where we are. What have been the successes and the challenges in our regions of the effective implementations of public health and social measures by our individual governments? Where are the shortcomings? Where are the successes of all these implementations during COVID-19? And also, what are the best practices? Some of our countries, we know we've had pandemics in the past, and chances we don't know that there might be future pandemics. So what is it that has been done in the past? What is it that's being done now? What can we take as the message, as the best practices in responding to pandemics? And then also then the idea at the end is to make sure that we make relevant knowledge and information available to the public in order to increase awareness, because that's what we want. We need to be able to communicate with the communities and raise awareness so that people know what's going on. And all of this is based on information that is evidence-based and something that can then be integrated into practice. So who are the partners? The partners for this particular project is South Africa, our colleagues in Mauritius, the DRC, and Zimbabwe. So the task, the working groups came together to put together this idea of how we can be in conversation with each other, and also looking at the best practices and successes and challenges in all these different areas. So we've been working together with the colleagues in these different areas to look at the policy briefs and be in conversation with them. So what are the sources of the policy brief? So who put together this information? Where does this data come from? As I indicated earlier, Resolve to Save Life as an organization is the one that has been spearheading and conducting the work in partnership with other organizations around the world. So in Europe, in the United States, here in Africa as well. So the different reasons. So that's where the source of the documentation that we shared comes from. And under Resolve to Save Lives, we also have an organization or a sub-organization called Prevent Epidemics. So you'll see there with that arrow showing that Prevent Epidemics works with or is part of Resolve to Save Lives. And what they do, Prevent Epidemics, is they do various types of activities. You'll see in front of you there where they're speaking about the work that they're doing. And for our specific project, what we're doing right now is that we're looking in particular at the public health and social measures as related to COVID-19. So that is the specific idea or the specific issue that we are zooming in on. Okay, and then Resolve to Save Lives, again, another part or another aspect of it is what is called PERC, Partnership for Evidence-Based Response to COVID-19. And PERC is the one that has been working closely in putting together the reports, in putting together the policy briefs that have been released I think every 2 weeks there are briefs that are being released in looking at the different statistics, in looking at the different responses, in looking at the work that's been done by the different countries. And so you'll see here, this is just one example. So the policy briefs, this is how they look like. So a brief on public health and social measures implementation in Africa. And so what PERC does is looking specifically at the African region. And so that's why we are using the information from PERC. And you'll see with this one, it shows there June 2 to 15. So it's a 2-week report in terms of what's been going on. So what has been changing? How have the statistics been changing? And how have the government been responding to some of the challenges that have been happening in the various regions? And when you look at the policy briefs, you will see from the table of contents, the areas that are covered, but also the issues and the activities that are also covered as well. So Africa COVID-19 situation, it's showing all the different, the metrics, the key trends, the disease dynamics, so all that information, and all of this is evidence-based information. So as and when the scientists, the scholars, the people doing the work are doing the work, the reports are then collated together and disseminated. And you will see that PERC's work focuses broadly on the whole region of Africa, so Central, Eastern, Northern, Southern, and Western Africa. But as I indicated already, that our focus is only on the SADC region. So that's what we've been zooming in on in terms of doing this work. And the aims and approach of putting together these reports is so that we can inform decision making about the implementation of public health and social measures. So what has been found, what work has been done, and so how can this then inform the decisions that are being made? But also the idea is to look at who are the intended audience in terms of the decision makers. And this also includes the various national task forces and emergency operating centers within the different countries. So these are the aims, to be able to do that. As we know, there were a number of national task teams that were put together in South Africa, for example, as a way to quickly respond to COVID-19. And they had a mandate in terms of the work that they were doing. And the approach here was to report and compile and synthesize and put all this data together on COVID-19 trends within Africa as a whole from multiple data sources, as I said. And for the purpose of our project, we were looking at the SADC region in particular. So this is put together, is summarized, is analyzed, and then is made available. So our idea is to then to look at all the information that's been put together, that has been analyzed, that has been put in a report, and say, how can we engage with this? And who does that? And who's going to do that? All of us are going to do that. And that is why we shared the documents with everybody. And that is why we arranged this webinar today, so that we can all have a conversation on this. You've all been invited because we believe that you have done work, you are the interested parties, you have experience in terms of the responses to COVID-19, knowledge around COVID-19 based on the work that you do as academics, as policymakers, as people in the business sector, people in government, non-governmental organizations, or as people who are residing generally in the SADC region. And then as I move towards conclusion, I just wanted again to note that this project has been funded by ASAF and the National Academies of Science, Engineering and Medicine of the United States. So it's a collaborative effort to make sure that the information that is put together gets disseminated and it gets interrogated. And these are the partners, the colleagues that I would like to acknowledge. These are the colleagues that we've been working together with in putting together this webinar. Our colleagues in the DRC, Zimbabwe, and Mauritius. So it's hosted by ZIMYAS in partnership with the colleagues from the other regions. And so with this, I would like to thank you very much, and I hope that this has assisted in providing an overview and background in terms of this project that we're embarking on. Thank you very much, and I hand back to you, Mayor.
Thank you very much, Puleng. That was a great background, and it's really helped me to understand the project much better and what you're trying to achieve. We are running a little bit behind time, but we have a question for you, and I also have one question. So the question is from, it doesn't have a name of a person yet, but the question reads, I would like to know more about what is being done to ensure a multidisciplinary approach in the uptake of this brief. Would you like to respond, Puleng?
Yes, we were very conscious in ensuring that in our attempt to involve the colleagues who could be part of the engagement and working and interrogating the policy brief, that we invite colleagues from various disciplines as it's an interdisciplinary conversation. So we have people from economics, from psychology, from political science, from communications. So basically, we're very conscious in ensuring that we have a very interdisciplinary conversation and response to the work that we're doing. So yes.
Thank you very much. And there's one more question, Puleng, from Pritisha Cuff. She says, thank you very much for the great presentation. And her question is, what strategies has the National Young Academy of Science used to share evidence-based information? For example, have you used any social media platforms?
Okay, I think it's important to know that this project started a couple of weeks ago, and we've been working on that. So for this particular one, and like today is a closed session, so we were very specific in terms of the people that we would like to have as part of the conversation. But in terms of evidence-based research and information that has been shared and coming from SADC, yes. As I indicated in some of the initial, at the beginning of my presentation, showing some of the initiatives that SADC has done, that information is available on the website, is available on SADC's social media platforms. So yes, that information has been made available, and some of the colleagues have even gone on a number of radio stations to engage on issues around COVID-19 and the work that's been done.
Thanks, Pauline. I don't see any more questions in the Q&A box, but I have one for you. You mentioned that you produce a policy brief almost every 2 weeks. To which policymakers are these being distributed, and have you had any feedback from them on the contents of it?
Oh, okay. We are not the ones producing the policy briefs. Yes, it's PERCS. It's the partnerships at a global level. But with PERC being specific, focusing on Africa as a region. So if you go to like Resolve to Save Life website, the information is available there. So I guess whether the easy access of this information, whether it's there, it's something that maybe we can debate. But I think the idea with this webinar, with this project, is exactly that, is to try and make sure that there is broader dissemination of the policy briefs and to ensure that the evidence-based data and information that is being produced on this regular basis is reaching the people that it's meant for. So this is, I think, the beginning towards that direction, to make sure that there is wider dissemination of these policy briefs, because I think it's important information.
Thanks very much, Pauline. That was really useful. Before I hand over to Sina, I have a note for Khulani. Khulani, I don't seem to be able to make participants a co-host, so that means I can't let them ask their own questions, which is why I'm posing it. If you could maybe, while Sina is doing the next session, just look at that in case Sina wants to be able to get participants to ask their own questions. Thank you very much. And Sina, I'm handing over to you now.
Thank you, Mia. Good morning, everyone. My name is Dr. Sina Prastran. I'm a junior doctor in South Africa, and I have an interest in community-oriented health. I've just been asked to moderate this next session with you, and I'm really looking forward to it. As it was shared, we have particular objectives for this webinar. We're hoping to, really have this as an opportunity to exchange experiences, discuss challenges, and encourage greater cooperation within the SADC region. The sessions we're going to have, we decided to use countries as a way of building this discussion. So we're going to begin in Zimbabwe, where an experience will be shared. And as that experience is shared, I'm sure there'll be discussion points that will arise. There are, broadly speaking, there are 4 themes that we're going to be looking at. The first is communication. So we're trying to understand like this flow of information that was distributed from policymakers to the grassroots. We're also then going to look at the built environment, the physical spaces, the community. The third theme that we're hoping we can explore is this partnership between public and private, political and economical relationships. And lastly, looking at the social-cultural sort of dynamics of what this pandemic brought. Of course, this, all broadly speaking, is a process of learning for us. So hopefully we will all learn something together and be able to contribute to this policy brief. So I'd like to begin by getting Dr. Annabelle Banda involved. Dr. Annabelle Banda is a lecturer at Gwanda State University and is currently the vice president of the Zimbabwe Young Academy of Sciences. So yeah, I'm going to hand it over to Dr. Banda to give a presentation based from Zimbabwe. Unfortunately, our colleague from Mauritius was unable to attend. So after Dr. Banda's presentation, we will then move to the Q&A and discussion. Go ahead, Dr. Banda, over to you.
Thank you very much, Mia. Can I share my screen? I've got a presentation slideshow.
Yeah, yes, Dr. Banda, go ahead.
Okay.
Golani is going to help you with that.
Greetings, everyone. You can see my slideshow. Hello.
Yes, we can.
Okay.
Yes, Dr. Banda.
All right. I'm going to share what is happening in Zimbabwe with respect to those subheadings that you provided. That is what I prepared, the way I understood or interpreted it. In Zimbabwe, with respect to COVID-19, people were made aware by use of posters with banners, radios, and then as well television was being used. Information was also shared via SMSs in phones. And then we had a non-governmental organization going around using their vehicles, like teaching or making people aware of COVID-19. Further on built environment, we realized that in Zimbabwe, the hospitals were refurbished, and then we had schools, training centers, and then colleges as well being refurbished so as to accommodate the COVID-19 returnees from other countries. And then the public and the private sector, they came together. You realize that UNDP in Zimbabwe had to come in with US 35.9 million budget so as to assist the government, so as to answer to those three pillars to prepare, to support and recover with respect to COVID-19. And then we had Net One and Tel One as well, bringing in money to assist in the COVID-19 pandemic awareness campaigns. Then we had hotlines being made in place for COVID-19 response by the Net One and the Tel One, the equipment, like ICT equipment being provided as well. Then economic and the political situation. During this time or the pandemic, 90% of the formal businesses were kind of like closed, therefore being affected. You realize that we have micro and small firms, textiles, having some problems during that time. As well, those in the large firms and then in the food sector, they didn't feel the pandemic impact because they used other ways of telling the public of where they are, and people go and buy and so forth, as well as they would bring their goods to the people. Then after some months, you realize 5 months of shutting, things opened up and now things are kind of like easing up. There are some places where they were not shut down, such as Zim plants. You realize that they were given that mandate, or they were made to continue producing. And then when it comes to political situation, I just took it on the aspect of politicians going around and campaigning. You realize that most people didn't campaign during this time because gatherings were restricted. And then social cultural behavior, you realize after people being taught or made aware of social distancing, wearing of masks, frequent hand washing, as well as restricted gatherings, People now are now aware that I should be away from somebody, I should not be close, I should be wearing my mask. This is something that we're doing every day. Up to now, we're also doing that. As well as the public transport in Zimbabwe, it was like stopped or reduced. But now things are opening up whereby you realize that people are now moving from one town to the other, but still is a bit restricted. And then on healthy, I took it in the aspect that when visiting hospitals and so forth, what is required, you realize that you are supposed to be wearing a face mask when you visit healthy facilities. And then you find the nurses also, they're doing the same. And then we have sanitizing points in and around those hospitals and so forth. And then educational and religious, schools were closed, and then up to now we're waiting to open up. Like us, colleges, students are coming to write, but face-to-face lectures are still not being done. As well, when they're coming to write, students are supposed to adhere to COVID-19 restrictions or ways of reducing its impacts, wearing of masks, and then we have strategic points for sanitizing what students are supposed to use. We are also engaging students via online using WhatsApp, and some are using Google Classroom. And then religiously, people were restricted to meet. Therefore, some were using Zoom prayer sections. I thank you. That was my presentation.
Thank you very much, Dr.
Hello.
Banda. Thank
Yes.
you. Thank you. You can stop the screen share. Thank you very much, Dr. Banda. That was very helpful, and thank you for presenting it in the context of the theme. We have somebody who's come in place of our Mauritius presentation. It's Surshin Naidu from the Institute of Natural Resources. She'll be speaking around the built-in natural environment and natural resource management that she was involved with. So go ahead, Surshin Naidu.
Thank you very much, Mr. Chair. Unfortunately, I can't share my screen. Okay, now it's allowed me to. So thank you, everyone. I think something that has been traditionally ignored in most health-related disasters and has unfortunately spilled over into this particular pandemic is the lack of attention that's been given to the management of natural resources and the environment. In fact, the earlier reports about lockdowns around the world having positive impacts on the natural environment have very quickly started to disappear as the implications of WASH, hygiene behavior, and the startup of a number of economies post-pandemic and post-lockdown begin to take effect. So building pandemic resilience through integrated environmental management is what a lot of countries need to start looking at going forward. This is an area, as I mentioned, that has not been given sufficient attention in our opinion. And by pandemic resilience, what I mean is the ability to deal with the shocks of a pandemic and recover from them. And this requires approaches and tools that permit society to control highly infectious diseases while preserving essential public institutions. Now, the problem with this is that many countries weren't able, South Africa included, weren't able to keep parts of the economy running during the lockdown period, largely because there was a lockdown in place, social distancing was required, and many economies are heavily reliant on natural resources and ecosystem services in order to function. And our point, and the point that I'd like to make here today, is while we think about disaster management plans and pandemic preparedness going forward, it's really important for us to understand that during pandemics such as COVID-19, we need to give sufficient attention to the threats posed by pandemic management to resource depletion and environmental degradation. And the initial symptoms of COVID-19 were evident in terms of a widespread underpreparedness in terms of managing pandemics, shocks that have exposed a heavy reliance on linear as opposed to circular economies. And whilst there were environmental positives, as I alluded to earlier on, these are quickly being eclipsed by increased waste generation, an increased demand for raw materials, a shutdown of recycling sectors, the increased production of single-use plastic products, and a widespread non-sustainable natural resource use, largely water. Just to give you a simple example, the surface disinfectants that have been used for environmental sanitization are quickly entering some of our natural water bodies. And there's very little that's being done in terms of understanding what are the implications for flora and fauna in the environment. Also, whilst hygiene behavior has been promoted in many parts of the world, hygiene behavior has been promoted paying little attention to the the need for increased availability of water, particularly in rural environments and rural settlements. Thank you, Mr. Chair.
Thank you so much, Mr. Naidu. That was very, very helpful and comprehensive. I see there's more slides on your presentation. I wish we could have gotten some more of them.
I will share that with the colleagues at the end of the webinar. I didn't want to dominate the conversation. I think we should leave more space for actually talking and discussing issues. I think my role was to just provide the aperitif.
Great, thank you so much. All right, colleagues, we have around 10 minutes for a Q&A. I see there's one question that has been sent on the all panelist group. Let's begin with this one. It's from a Webster Guming Doga. I hope I said that right. Okay, to the last two presenters, we have seen in many countries, politicians and policymakers breaking COVID-19 restrictions and guidelines. Are politicians so supportive of these COVID-19 non-pharmaceutical interventions? The second question from Stanley is, how was science able to address fake news around mask wearing, carbon dioxide inhaling, sanitizer in the sun, and burning cars and other stuff that communities were exposed to? Will science always be reactive or proactive for future pandemics? I'll leave it to Dr. Banda and Mr. Naidu. Feel free to respond.
So, sorry, Mr. Chair, can you just repeat that question?
There were two questions made. The first one has to do with the support of the politicians in terms of non-pharmaceutical interventions in relation to, in some countries in the SADC region where politicians broke some of these guidelines. And the second question has to do with fake news. So the question is around, like, how can we be proactive as scientists rather than reactive in future pandemics? I hope that was clear.
Yes, so just to respond to the first question, I think the level of support for lockdown measures and pandemic management plans from politicians was not always coordinated or cohesive. And whilst there were some early victories in countries like South Africa, as the pandemic progressed, we slowly saw that different government departments and different politicians started to address the priorities of the individual departments rather than the priorities of the disaster management plan, so to speak. We should also mention at this juncture that a lot of countries have actually not submitted a comprehensive disaster management plan as prescribed by the WHO. In fact, the South African disaster management plan makes very little provision for health disasters. The plan was originally designed around environmental and political disasters. So I think the support from politicians, if that's what the question was about, and their few incidents where the politicians didn't actually adhere was largely as a consequence of the fact that the plan wasn't made clear right at the start. And we went into a pandemic with politicians themselves not being aware of the disaster management plan. In terms of fake news, I think this speaks to the urgent need for science advisory platforms and for platforms to be created for direct corridors of communication between scientists and legislators and policymakers. I don't think enough is being done in Africa, particularly in the SADC region, for this. I hope that addresses the questions.
Thank you, Mr. Naidu. We have two more questions. Oh, go ahead, Dr. Banda, yes. Go ahead.
I realized that, yes, politicians really helped very much. You realize they didn't call any gatherings. So somehow they were adhering to the COVID-19 reduction, as well as this fake news. I realized that, yes, it circulated on WhatsApp, but you realize that most people do not have access to WhatsApp and so forth, as well as there was active engagement of non-governmental organization teaching people on face mask wearing, sanitizing. So people are still continuing doing that. I thank you.
Thank you, Dr. Banda. Dr. Naidu, may you please stop screen sharing? We have 3 more comments and questions. I hope we can get through them before 11, where our next session begins. First we had was from Hadia Hosseini, from one of the attendees. The question is, hello, thank you for the nice presentation. Can you tell us a bit on sensitization being done on mask wearing and disposing of them? So her question is related to the use of masks and the disposing of them. We then have another question that was sent to the panelists, where Marie Manjoro is thanking Suresh Naidu for the presentation, and she's asking that, well, the comment is, I noticed there is overuse of sanitizers. For example, when one visits a shopping mall and entering many shops, could that not have a health impact to humans too? So this question is related to the use of sanitizers and the health impact related. And the last question that was sent from Prof. Puleng is, I'll quote, in what way do you think governments could better respond to challenges around the ecosystem, and how it is interlinked to pandemics in particular? All right. I think we can go on a little bit longer because our speaker from DRC is not with us. So let's go on until 11:10. We have 14 more minutes to respond to these questions.
Mr. Chair, can I ask that you pose one question at a time, and then we as panelists address that question and then move on to the next?
Of course, sorry, I thought we only had a few minutes left, so we've just extended this session. All right, let's begin with the first one. So the first question had to do with sensitization in regards to mask wearing and disposing of them. Maybe the panelists can respond, and I'm opening this up to everyone actually.
Mr. Chair, if I can come in there, I think the sensitization around mask wearing has been particularly good. A number of the SADC regions have actually launched audio and visual media campaigns around the use of masks. In South Africa, we have seen education around mask wearing being translated into multiple national languages. I've seen this in other countries in Africa as well. However, one must understand that our domestic waste profile has never included PPE, masks, gloves. I mean, that was traditionally associated with the health sector. So sensitization around the disposal of masks has been extremely poor. We are already starting to see masks pop up within coastal environments where people are disposing of masks at sea or on land, where they move from land sources into oceanic or aquatic sinks.
Thank you very much.
Hello?
Go ahead, Dr. Banda.
Yes, I would like to comment on excessive use of sanitizers. That is something that I've realized on my own as an individual as I'm going in town from shop to shop. Especially it has an impact when one is eating. You know, you're supposed to wash your hands before you touch any food. I think there's need, therefore, to make the public aware that these sanitizers, they are dangerous. Somebody has to carry or use water. If they want to eat, they have to wash their hands. I thank you.
Thank you, Dr. Banda. Let's go to the second question. The second question was sent to the panelists, and it was a question regarding the shopping mall and the overuse of sanitizers. I think Dr. Banda has answered that. Just wanted to give a chance to Dr. Naidu in case there's anything more you want to add before we move to the last question. The next question, sorry.
Yes, some countries in the SADC region are experiencing serious shortages of ethanol. And there are some early indications that some pandemic profiteering efforts have unfortunately started to use methanol, albeit in small amounts. And there have been serious issues around human and environmental health around the use of methanol. And we need to be very, very careful. There are also household ethanol derivatives that have been used in sanitization products that have been made available within the black market. So sanitizers that are sold in the informal economy that do not come through some sort of medical registration process. And there were serious oversights. We were all in a period of panic, and I don't think that there was any regulation of the industry initially, but I think most countries have managed to get that together right now. However, I don't think there was sufficient education, public education, around the sustained use of sanitizers. Yes, we have to sanitize, but I don't think there was enough effort around the fact that sanitizers can damage the epidermal layer, sanitizers can affect people who have skin conditions such as eczema. So I think a lot more could have been done. But this was an unprecedented event in human history, and we shouldn't be too hard on ourselves. We should learn from it.
Thank you very much. We have this last question from Prof. Puleng, and then I have my own question that I'd like to ask. Prof. Puleng has said to Dr. Naidu, thank you for bringing in the need to engage the importance of built environment in the ecosystem. in what way do you think governments could better respond to challenges around the ecosystem and how it is interlinked to pandemics in particular? Essentially, what's the way forward? Yeah.
Yeah. So I think the core understanding of the role of environmental management in pandemic management needs to be addressed. So government needs to bring environmental scientists into the fold. In fact, the National Command Council and the advisory service was largely dominated by scientists that had a focus on health. And while that is important, one must understand that even though we are dealing here with an enveloped virus, which does not survive in aquatic environments for extended periods of time, the hygiene practices that were prescribed to deal with the disaster led to enormous volumes of wastewater being produced. And in informal settlements, where this wastewater is not disposed of correctly, it can have huge health consequences, particularly for children and pregnant mothers. So my simple answer to that is that environmental scientists and scientists that are integrated environmental management practitioners need to be brought into the fold in terms of designing the country's revised disaster management plan going forward. And I'm sure we would all agree that there's a need to revise the plan.
Thank you so much. That covers the questions that have been sent. We have a response from Marie Amanjoro. Many thanks, Dr. Banda, for the response. I concur with you. I also suggest that studies be done on overuse of sanitizers for evidence-based information to be gathered that will be used to inform policy as well as educating the society properly. Thank you very much, Marie. I have a question around communication. This question is like a reaction to Dr. Banda's initial presentation. This is personal, but when I was observing the way information was being shared during the initial stages of the pandemic, a lot of it was in the form of slogans. And just a question I have around any evidence-based research around whether or not the use of slogans is the most effective means of educating a population, and whether or not a more detailed, deepened educational program may have proven better outcome.
Thank you, Sina. I have nothing much to say. I think I'll look at that. Thank you.
Thank you very much, Dr. Banda. We have 5 more minutes. If there are any other comments, questions, discussion points from any of the panelists, attendees, please feel free.
I have just a few recommendations I would like to share.
Go ahead.
With respect to pandemic, COVID-19. Like you realize the education sector had suggested that modules be prepared so as to cater for the marginalized children, school-going children. So can we have that being put in place? We need modules. You realize they do not have access to the internet. And then we also require COVID allowance to be made or to be availed in cash. And we have a retesting of those who were retesting of the positive, those people were found positive to be retested. And then we need continued public health awareness. the use of native language to disseminate information should be used. You know, here in Zimbabwe, you've got Ndebele, you've got Shona, you've got Kalanga, all that needs to be put in place. And then those people who are involved in the front line for COVID or the COVID-19 task force, they should undergo some bit of, is it psychological therapy or test, or so seek some sort of counseling. I thank you.
Thank you very much, Dr. Banda. Are there any responses to Dr. Banda's point? Okay, well, I think we can move to the next session. Thank you very much to Dr. Banda and Dr. Naidu for beginning this process of looking at best practice. The experiences and insight that was shared really generated a lot of thoughts and provoked a lot of ideas within the panelists and the attendees. I'm going to hand over to my co-moderator, Mia, who's going to take us through the next session.
Thanks very much, Sina. We'll now move on to learning about lessons and best practices from South Africa. And as Sina has mentioned, we unfortunately don't have a speaker from the DRC. So we'll move on to Professor Stephen Friedman. But before I introduce him, I'd like to let you know that Tatu Marukeng from the hosting team is able to, if you'd like to ask a question, to enable your audio or video, but we would need you to indicate that you would like to ask it that way along with your question in the Q&A box. So if I only see the question, I'm going to ask the question. If you have the question and tell me that you'd like to ask it yourself, then I can give your name to Tatu and she can enable your audio and video, but that means that you can't ask your question as an anonymous person in the Q&A box. I would need to have your name, otherwise Tatu wouldn't know who to enable with the audio and video. So let's move on to Professor Stephen Friedman. He is a research professor at the Politics Department at the Faculty of Humanities at the University of Johannesburg. And he's a political scientist who has specialized in the study of democracy. Recently, he wrote an article in The Conversation, which is titled, "South Africa is Failing on COVID-19 because its leaders want to emulate the first world." Over to you, Stephen. We need to unmute you. Professor Friedman, we need to unmute you.
Thank you very much for the introduction. I thought I should talk to you in person rather than behind an icon. Thank you for the invitation, and I really want to commend the organizers on inviting a political scientist, because I think that one of the problems in South Africa, certainly, and some other parts of the world in dealing with this pandemic, is that the social sciences are assumed to have nothing of interest to contribute to the fight against COVID-19. The South African government has appointed a very large, well, they've just been replaced by another body, but that's another matter, Medical Advisory Council on COVID-19, which does not have a single social scientist of any sort on the entire panel, which I think is one reason why South Africa is not done particularly well at handling this problem. Now, you will have heard from the introduction that I'm very critical of the South African government's response. And I'm less concerned in this very brief session to denounce the South African government's response, but just to indicate that I think that the reason South Africa has failed to deal with COVID-19 effectively has a great deal to do with politics. It's not simply because, as is the case in some other parts of the world, that people have ignored the science. In fact, you know, it's been one of the mantras of the government here that They are listening to the science. Now, just a word on why do I say South Africa has done badly at handling COVID-19. It's perfectly true that our health systems seem not to have faced the pressure that those in parts of Western Europe did. But the stark reality, as I speak to you this morning, is that the official number of COVID deaths and cases in South Africa are roughly equivalent to that of the entire African continent combined. So in other words, we have as many official cases and deaths as every other African state together. And it doesn't seem to me that that can be regarded as a success. The technical reason, as I understand it, others, including the chair of the session, probably know far more about it than I do, but the technical reason why this has happened is because despite a huge number of tests, the processing of tests in the national laboratory was too slow to enable any kind of effective tracing of contacts of people who tested positive. And the evidence throughout the world is that if you really want to be effective at dealing with COVID-19, you have to get testing and tracing right, and this unfortunately wasn't done in South Africa. But I'm more interested, rather than going through a checklist of what was done wrong, in suggesting out of that article, which has just been quoted, why things have turned out the way they have. And the first point I want to mention before I get on to some of the issues of the science is that if you want outside Africa to look at an extremely interesting example of how to deal with COVID-19, you need to look at the state of Kerala in India. Because various people, journalists around the world don't like nice things to be said about Kerala, we're now hearing that Kerala started off dealing well with COVID-19 and is now doing badly. Well, there is a greater prevalence of COVID-19 in Kerala than there was at the beginning. But the last time I looked, which was a few days ago, Kerala has about 40,000 cases in a population of 35 million and a fatality number of 169, which is not even comparable to the South African one. And the purpose of mentioning Kerala is that I think the way politics are done in Kerala, and I keep on stressing, we cannot deal with scientific challenges with a purely scientific response if society is involved. I mean, a participant in the previous section suggested that you can deal with fake news by increasing science education. I'm afraid you can't deal with fake news by increasing science education because the people who spread fake news reject science. So the fact that scientists have concluded something doesn't mean that the fake news brigade will take it seriously, or the people who listen to them will take it seriously because they believe that scientists are people who mislead anyway. What Kerala does, and what South Africa did not do, and which in South Africa's context was essential, is try to form a partnership with citizens to deal with COVID-19. Now, the article the chair mentioned talks about, South Africa thinking it's, looking always to the first world. The reason I think South Africa has done a lot worse than the rest of Africa is that, in effect, South Africa's profile is much more that of a Latin American country than it is an African country. And by that, I mean not that the vast majority of people in South Africa are not Africans. But if you look at Latin America particularly, you see there's a very stark difference between the affluent section of the society and the rest of the society. So if you look at South Africa today, you see that in terms of COVID, as we're discussing this morning, you have a fairly well-run, for example, private curative health system, But for the vast majority of the population live in circumstances for which do not enable them to use that system. In the suburbs of South Africa, as major cities, the kind of normal, if I can put it this way, the standard health measures which were used in Western Europe can work in those areas. They obviously cannot work in situations where people's conditions of life are very different. So at the start, South Africa was faced with a situation in which it had to deal with the reality that most of the methods which had been used in Western Europe and North America simply, and in places like South Korea, which has much the same social and economic profile as Western Europe and North America, could not be used with the majority of citizens here. And what I would argue you do in a situation like that is that you form a partnership with citizens. You go to the citizens' organizations, you go to people at the grassroots, and you work with people on COVID. Because I think one of the things that scientists tend to do, and I think there have been elements of it in our discussion this morning, is that they tend to regard citizens as people who are a problem rather than part of the solution. So in other words, citizens are regarded as people who have to be told what to do, have to be regimented, have to be educated, because otherwise they get they'll do themselves harm. I think the evidence is overwhelming in South Africa that most citizens in South Africa desperately want to protect themselves from COVID-19 and are unable to. So the way in which you deal with that is that you form partnerships which enable you to work out what the constraints are. I mean, a very obvious constraint, which we haven't talked about this morning, and this should be obvious. You cannot expect people to isolate. I mean, there are obviously problems here about the physical spaces people live in. But beyond that, you cannot expect people, who are earning an income, who are people living in poverty, to isolate if isolating is going to cost them their livelihoods. So unless you put in the economic support systems which enable people to isolate without starving, then you're not going to have a positive outcome anyway. So I think that was a chance that was missed. And I think the chance was missed, and that was the thrust of my article, because I think that the entire South African response has been based on the perspectives of, to use that dreadful word, the first world section of South Africa rather than the third world section. So, for example, I would argue that one of the reasons why Western Europe and North America has done very badly at handling COVID, beyond certain problems of political leadership, which are very important, is the fact that they have curative medicine systems. They are top of they're world leaders in curative medicine. But I keep on making the point with COVID-19 that curative medicine is of a limited value if you don't have a cure. That may well change. We may find the curative medicine skills becoming more and more important as we get into questions of vaccines and more effective cures, etc. But certainly at the stage of the pandemic that we're still in, curative medicine doesn't really help that much. We're not even sure. We as South Africans have never been told how effective curative medicine has been. We've never been told how many people who were admitted to hospital were helped by the interventions they received. And it's simply been assumed that curative medicine always works despite the problem I've identified. If you look at the beginnings of the South African response, and I know I'm running out of time, but I'll try and fast forward this as much as possible. We tend to forget about these things. Right at the outset, the consensus among the South African medical scientists, articulated by people like Professor Karim, who was then chairperson of the Medical Advisory Council, was that, and I'm using, I think, almost identical, I'm virtually quoting Professor Karim directly, that a severe outbreak of COVID-19 was inevitable in South Africa because no other country had avoided it. And now, with respect to the professor, that's not correct. By the time he was speaking, it had become quite clear that some East Asian countries were avoiding a severe epidemic. I don't have time now, and I'm sure it would be very boring to produce a long list of countries around the world which have avoided a severe epidemic. And I think a lot of the problems with the South African response was based on the fact that quite explicitly, I'm not reading anything into this, we were told throughout that the purpose was not to prevent a severe epidemic. The purpose was to make sure that the health system was ready. That all of that makes sense from the perspective of Western Europe and North America. All of that makes sense if what you have in your head is a model in which curative medicine is what enables you to deal with a pandemic, and public health measures and preventative medicine is secondary. And I've already exceeded my time, and I don't have time to go into all the details, and perhaps if people are interested, we can take it up in discussion. But I think that initial assumption, based on the fact that it seemed to be impossible to avoid a severe epidemic in Western Europe and North America, not in other parts of the world, has really shaped the South African response. And while I have no idea, sitting from a South African vantage point, why the other 50-odd countries in Africa have managed to keep their infection and death rates as low as they have, I certainly feel very strongly that South Africa's very high figures by continental standards are a result of the fact that our entire scientific response has been based, on a focus on Western Europe and North America, and B, on an assumption, as I said earlier, that citizens are not partners in the fight against COVID, that they're problems who have to be controlled. I've obviously skipped out a lot of details, but I'm aware that I've already taken 5 minutes more than the 10 allocated me, so I think I'll leave it at there, and hopefully we can take this up in debate as people respond.
Thanks very much, Prof. Friedman. It was a really interesting presentation, and I think that has set the scene for a lot of questions. Just before we go to Q&A, someone in the Q&A box has raised some points about the Democratic Republic of the Congo. Ahadi raised it. If you all wanted to have a look at that, and if there are questions around those points, please feel free to post them as well. I have seen that someone raised their hand. There's one question in the Q&A box, but there's also Tendai Mafuma raised their hand. Tendai, would you like to ask your question live? I see Tendai is muted at the moment. I just want to know, did you raise your hand for the question or just to type something else? We haven't seen the comment. While we wait for Tendai to let us know, there is one question, Prof. Friedman, let me just get to it. From Tracy, she wants to know, do you reckon the pandemic has evolved into a political problem before it is a health problem?
Well, I think that it always was a political problem. I mean, you would certainly, and I'd say this internationally, globally as well, people sort of said, well, why has COVID been politicized in North America, in the United States? Well, it's been politicized in the United States because there are certain features of American politics at the moment which make that inevitable. And you can say the same as some other parts of the world. So what we had in South Africa, which I didn't have time to talk about, the debate about South Africa, another way in which it gets politicized in particular sort of ways. The debate in South Africa has purely been about what I call the lockdown debate. So you have very polarized positions. Some people say, we went for a hard lockdown earlier on. My understanding was that the hard lockdown was supposed to create the space for testing and tracing, but be that as it may. And in a sense, all the debate in which the scientists got sucked in was about, do you have a lockdown or don't you have a lockdown? Now that's because we have a certain political polarization here, in which there's a section of the very vocal section of the population who believes that a majority government shouldn't tell people in the suburbs what to do, and that's a reality we always sat with. I think the fact that we've had a debate about the lockdown, which is about restrictions which affect people's freedoms, rather than a debate about testing and tracing, which is about have we been effective at curing people, at enabling people to not get the disease, is a result of the fact that the people in South Africa who tend to drive the national debate are middle-class people who haven't been affected as much by COVID-19 as people in the low-income townships and shack settlements. So all of these are political issues, and the point I'm making is that it's not that it became a political issue. It's unfortunately one of the political realities I think we need to be aware of, or scientists need to be aware of, is that if you're talking about public health issues and you're talking about pandemics, there are always, if you like, underlying political conditions which shape the way a society responds to a pandemic.
Professor Friedman, on that issue of the politics that shape an epidemic, one of the political issues with regards to COVID-19 that has been raised in South Africa is that the response of the government is so much more evidence-based as compared to HIV or other epidemic. But you've now raised that you feel it also wasn't an effective response. If you compare our response, COVID-19, to the HIV response, what would you say?
Look, I think it's a very important question and a very interesting question, and for people who there may be people on the webinar who aren't familiar with the South African background. I mean, when we had to deal with HIV/AIDS, the problem that we had to face was that the government in effect rejected the science and made all sorts of alliances with AIDS denialists, etc. But I think this is a very different situation. Because by the time HIV and AIDS arrived in South Africa, it was pretty clear what you had to do about it. The science was pretty established because it had been around in other places for quite a while. So when people argued in South Africa about the science debate in relation to HIV and AIDS, what they were actually saying, because that's really what it revolved around, is you have to put an effective treatment program in place. You have to roll out medication to people. You have to deal with mother and child transmission. And all the science on that was established. The only people who differed from that were a few people with some very dubious agendas. But of course, that's not the reality with COVID. The reality with COVID is that the science is evolving as we speak, and is not really evolved because COVID's only been with us for 6 months. So that doesn't mean that what scientists are saying is irrelevant. But I think the idea that there is a science of COVID which we should apply, which was true of HIV/AIDS, is not true. I mean, just to give you one example of that, I spend quite a bit of my time, because I should reveal that it was just confirmed this morning, I'm writing a book on this. I spend a lot of time looking at what medical scientists are saying in some other countries. And it's the polar opposite of what they're saying here. So the medical scientists here all say a major epidemic is inevitable. There are very strong voices in the scientific community elsewhere who are talking about how you can contain the virus, how you can make sure that it has as little effect as it's had in South Korea and New Zealand and Taiwan. So my point in essence is there is a scientific debate on COVID-19. The science is not cast in stone, and we didn't have that scientific debate here. We were presented one version of the science. We were told that was the only version of the science, and I'm afraid what didn't happen was a public debate on whether that science was the science we should have gone with.
Professor Friedman, there is a question for you on mental health from Dr. Tuzama, who says, can you please comment on the impact of the restrictions on mental health? So what impact did the restrictions have on mental health? Is there any correlation? I'm not sure if you, do you feel comfortable with that question as a social?
Well, I'm simply saying that, look, to be quite honest, I'm not aware of any data that has been produced on that, would be persuasive. Simply as a non-medical person, I would have to say that if a pandemic and the restrictions that went on with it did not have an effect on the mental health of people, it would be extremely strange. Precisely what that effect was, I'm not aware of the evidence, but we can assume that it did. It would be very odd if it didn't.
Thank you. I wanted to ask you for examples. You mentioned that the government should have had partnerships that it formed with citizens in South Africa. Could you give us one or two examples of what type of partnerships you think would work well?
Well, I think it's a question. I mean, let me give you, I'm sorry to keep on harping about Kerala, but it just seems to me to be such a good example. Okay, in Kerala at one stage early in the pandemic, they discovered because the whole way government works in Kerala for a variety of historical reasons is that there's very good contact with citizens' organizations on the ground. They discovered that there was some resistance to public health measures in a particular area. The response was that the Minister of Health for Kerala took all her appointments out of her diary for the day, traveled to the area and spent the entire day talking to people in the area about how COVID worked and what they could do to protect themselves, etc. And that is a starkly different response to the attitude you saw in South Africa, which was about restrictions, about policing, about troops, etc. Obviously, there are a lot of examples of how this worked very well in South Korea. But people tend people in Africa tend to dismiss the South Korean examples because they say, well, it's this highly developed, rich country and we can't learn from a rich country. I'm not sure that that's entirely true. South Korea has a lot of technology, which may be difficult to import here. But I think it has approaches which work here, and a lot of these approaches, once again, I mean, obviously the South Korean Minister of Health doesn't have to travel to the Shak settlement, but the South Korean Minister of Health does have to get on social media and spend a lot of time explaining to people and listening to people. I mean, listening is crucial in this situation. There are examples around the world. The reason I usually quote Kerala is, as I say, the other examples tend to come from societies which much stronger health infrastructure. So people tend to say, well, that doesn't fit South African conditions, although I think that it does.
Thank you very much. We have just been told we can go on for a little bit longer with questions for you. I don't see any, I do see questions in the Q&A box, but while I read them, I would like to ask you a little bit about your previous comment that there is no established science and that we heard one version of the science in South Africa. As a journalist, I saw a lot of debate, for instance, about lockdown science. Is it good to have a hard lockdown or a bad lockdown in the media? And I've also seen the government acting on science around treatment. For instance, our guidelines around the treatment of hydroxychloroquine, which shouldn't be used, is based on World Health Organization recommendations. Our guidelines on how to use steroids or anti-inflammatories for severely ill COVID-19 patients are all based on studies that have been published in peer-reviewed journals and on recommendations of the World Health Organization. So while there is a lot of debate on, how to prevent COVID in which environment and what sort of measures would work well in certain environments better than in other environments, there has been scientific, in my opinion, actions from the government when it comes to treatment options with a little bit of science that we have on that. What would your comment on that be?
Well, I mean, obviously what you say is correct in the sense that there were some of these debates, but incidentally, one of the points that I need to, except for the lockdown debate, and the lockdown debate, as I said earlier, was absolutely all-encompassing. I mean, everybody had a view on the lockdown. I mean, I have an article appearing in a newspaper tomorrow morning making the argument that, I mean, firstly, from my experience, whenever you made a comment about COVID in the public debate, somebody would demand to know what your position on the lockdown was. And all discussions of other issues were funneled into this lockdown thing. But beyond that, look, there were a few marginal discussions of chloroquine, etc., but they were fairly marginal. My problem with the lockdown debate is that I think it was a symptom rather than getting to the essence of the problem. It's no surprise we had a lockdown debate in South Africa because, as I indicated, I mean, there are a lot of suburban people who get very hot under the collar. One of the ironies, incidentally, which I didn't have time to deal with in my main presentation, is that the restrictions that the people in the suburbs were getting hot under the collar about were actually put there to control people in the townships and the shack settlements. And the government made that very clear. You know, we had a ban on cigarette sales. When the relevant minister was asked, she said, well, people in townships share cigarettes. We had a ban on hot food sales. When government was asked, they said, well, people in townships sell cooked meat and pap on street corners, and we can't have that, and so forth. So that debate was inevitable. But for example, when media reports, which I think really sums up a lot of the South African debate to me, when media reports indicate that the testing is not working because results are taking 2 to 3 weeks to come back from the laboratories when you need them back in 48 hours maximum. There wasn't a public debate on that. I mean, I tried to instigate a public debate on it. It didn't happen. We have a particular example of this in South Africa at the moment, which I've written this particular column on, which is that for people who are not South African, you may not be aware, the South African government in the last few days has introduced trying to encourage people to download on their phones an app, a COVID alert app. And there's this huge debate now about whether it's government controlling people and whether they're going to use the app to control your movements, etc. There hasn't been any debate at all on whether the app's actually going to work to control COVID-19. Nobody seems at all interested in that question, and that's what I think I'm trying to get at. We haven't had we've had a debate in this country about whether lockdowns work or not. Incidentally, the other things we haven't had a discussion about, you know, where very often media in South Africa demand information on a lot of things. I don't think my point about the health system is trivial. You know, I assume by common sense that a fair number of people who were admitted to hospitals were probably able to survive because they were admitted to hospitals. But we never had serious, we never had serious data on this, serious information on this as well. You know, I put it to one of the senior scientists who was prepared to discuss this, and the response I got was, "That's a very good question. I'll come back to you." And he still hasn't come back to me. So I think there's a lot. You know, I don't say, you know, I'm belaboring the point, but I think what was never discussed seriously was a debate about whether the methods which were being used to deal with the pandemic were the most effective methods possible.
Okay. Thank you. We have two questions for you. The one is from Sally Gander. It's quite a long comment, so I'm going to read it. You could perhaps see it in your Q&A box as well. It says, Mr. Friedman, thanks for the interesting presentation. Much of the way that the pandemic is spoken about appears to be from an individual or country level response. And this largely ignores the impact that the lockdowns and responses have had on migrant populations and other persons on the move, for instance, refugees, asylum seekers, and so forth. As we start decreasing restrictions and reopening borders, how can we ensure that the response taken is more regionally focused and that it is focused on better partnerships with individuals or communities on the move?
Sure. No, thank you. That is an excellent question, but unfortunately, it's not one that I can give a very encouraging answer to, because you're absolutely right. I mean, this is a very important part of the issue, but it really underlines the point I was making earlier about the pervasiveness of politics. You know, you may have, you know, people have commented globally since COVID started on the extent to which, you know, people in my field and economists, etc., used to talk endlessly about globalization. And nobody talks about globalization anymore because all the